Thank you so much. I feel so honored to be here today. I've been working with Longevity for several years now. They're an incredible organization. I think back to, a lot of friends and family ask me, what are the big changes in medicine of recent, within the past decade? And I really use as my number one example is lung cancer, and the way we approach lung cancer, diagnose it, and treat it, it's really just been revolutionized. It's so much different compared with 5 years ago, let alone 10, 20 years ago. And I think it's what really puts the hope in, very appropriately so, a hope summit. So I'm excited for you, all the talks this weekend, and the purpose of this, I know a lot of you have been living with lung cancer or have loved ones who have gone through the initial diagnostics of this. Some of this may be reminiscent of some of that, but I wanted to go through it again at the start of this conference. So, I thought it'd be helpful to start with a case. You go to an emergency room and you have chest pain, and they check your heart, which is really the first thing, and your heart's okay. And then they do a CAT scan of your lungs, and they find a left lung mass and lymph nodes that are swollen in the mediastinum, what we call mediastinal lymph nodes. And they say, well, your heart's okay, but you need to see a doctor for this lung mass. And I think I'm always a big fan of defining our words, defining terminology. Lung mass is really just a fancy radiology word for a large spot or a lump on a CAT scan of the lungs. The fancy word for a small spot is called nodule. The fancy word for a large spot is mass. The difference is 3 centimeters. The word mediastinal is really just a location in the body. It's a location between the heart and the lungs, between deeper in your chest. And lymph nodes are small bean-shaped glands throughout your body. Many people are familiar with them. When you get strep throat, you have enlarged glands under your chin, but they're really throughout our body, and they do things like fight infections and heal parts of the body. So you leave the emergency room, very appropriately so, scared, and you go to your primary doctor, and a referral is made. So you say, well, who should we see first? Should you see a pulmonologist? Do you see someone like me, an interventional pulmonologist? Do you see a surgeon? Do you see an oncologist? Do you go right to an interventional radiologist? In reality, there's really no best answer. And a lot of you may have kind of said, well, I went to this person, or I went to this other person first. A lot of it depends on the resources and expertise of your community and the medical center where you're at. That doesn't mean there's a wrong answer. Many times people start with one of these specialists, and what really hones in on the approach and the treatment of these things is a big multidisciplinary team. So you go to one person first, and many times people get added to your team. Well, people say, well, what is an interventional pulmonologist? Some of you, I see some familiar faces in the audience, are already familiar with people like myself, but we are general lung doctors, trained like any other lung doctor out there in pulmonary and critical care. But we have this extra training in a specialized area of the lungs. One of those areas is really anything abnormal on CAT scans and x-rays of the lungs. So I deal with spots in the lungs on a day in, day out basis, lung cancer screening, airway problems, things on the lining of the lungs. And by extension of that, I do a lot of minimally invasive procedures, non-surgery procedures, some of which are fancy cameras in the lungs, diagnosing spots, taking biopsies, and opening up airways, and taking out fluid from outside the lungs. You see this specialist. I think this is probably my most important slide. And you're very scared and worried. And people say, they come and they say, I'm seeing you for this big mass in my lungs. And they say, I'm really scared. And I say, what are you scared about? Say, I'm scared about cancer. But I think the next question is much more important. Well, what are you afraid about? Cancer. And I think it's very important, especially for people that you might know in the future going through this journey, is to define your worries, concerns, your fears specifically. and be very specific as possible. Don't hold anything back. Some people, in fact, most people say, well, I'm afraid of dying. I'm afraid of whatever this is killing me. Others are afraid because they say, well, I heard the word cancer and I've had a loved one or family or friend go through horrible chemotherapies and be really sick and change their life. I've had people tell me, well, I have a very important family event in a month or two. I just can't miss this. I'll deal with whatever I need to, but I'm just terrified. Or they don't want to be a burden, or they don't want to lose their hair. I think it's critical to define your worries specifically, because we don't just treat a spot on a scan. We don't just treat a cancer. We treat a person. And many of these things, the other thing I think people worry about is they say their worries, and they're worried it will change the recommendations. I think that's the farthest thing from the truth. Any good physician or practitioner is going to give you standard of care, the right approach, but you tailor that to what you need and what your needs are and your fears are. So in the initial evaluation, I'm asking myself two main questions when you're coming to me with a spot in your lungs. And this is the 10,000-foot view of things. Number one, what is it? Number two, what do you do about it? It's kind of the most simplistic way of looking at it. A spot in a lung is not a disease. The question is, what is it? And there's hundreds, if not thousands, of things that can cause spots in the lungs. And at this first visit, we're really just in that first question of what is it? Emergency rooms or other doctors or radiologists might write words like, we're concerned about cancer, or we're worried for this, or we're concerned about that. But really, in the end of the day, we're really in this first question of what is it? And I think it's important in this what is it question is a scan alone cannot provide a diagnosis. The word cancer, many things that are not cancer can cause changes on CAT scans and x-rays of the lungs, but even the word cancer is an extremely broad word, almost to be unhelpful at the start. Even the word lung cancer, and this is the revolutionary approach to lung cancer in general, is an extremely broad word. That means hundreds, if not thousands, of different things. So the whole art of all this is how do we figure out what's going on without hurting you in the process? So on the forefront, from my level, is assuming it's a lung cancer, there are three important questions to address. Number one, what kind of lung cancer? Number two, where is it in the body? That's the stage. Number three, is it causing any symptoms that need more urgent addressing or palliation? In asking the question, what type of lung cancer is it? My colleague Rashida is going to be speaking about this in much more depth, but the word lung cancer, as I said, is a very, very broad term. It's not like in the movies where they say you have lung cancer and everything else gets blurry and there's nothing to do. It means literally hundreds and thousands of different things. But what is important is it requires a biopsy. And the word biopsy just means taking a small piece or a small sample. So you could look at it under a microscope and know. Well, what's the stage? Essentially, that's the term, where is it in the body? If it's a cancer, where has it spread to? And we look at stage in two ways. The clinical stage, that's kind of a best guess of where it could be, oftentimes made by, once you have a diagnosis, by imaging. You can have findings that say, we really think it's also over here. And then there's the pathologic stage that's confirmed by biopsies themselves. And Rashida is going to speak about, and I'm sure many people in this conference, about the more specifics about staging. People say, well, I got the CAT scan, it showed a spot. My doctor told me, or nurse practitioner told me to get a PET scan and a brain MRI. Well, what's the role of these other scans? PET scans are very helpful and very important. PET scans look at the whole body and look for areas that light up, as we say. What do we mean by lighting up? PET scan looks for areas of cells that are dividing more rapidly. Many things can make cells divide more rapidly. Cancer is not the only thing, and PET scans are not perfect, but they could kind of help you hone in on different areas. PET scans are not very good at looking at the brain, so oftentimes people get a brain MRI as well. But then the real crux of knowing what's going on is doing a biopsy, taking a sample. And I think I wanted to talk about three main ways to get a sample of what this is so you can know what's going on. And the goal of choosing which modality, which method to get a sample is oftentimes saying, how do we get the correct diagnosis and stage in the most safest and most efficient manner? That's how we decide on which, most of the time, these three different modalities, which I'll just briefly talk about. The first, which is what I do on a day-in-day-out basis, is bronchoscopy, which is essentially just a fancy camera into the lungs. Basic bronchoscopy is putting a simple camera in. Many people are familiar with colonoscopies or endoscopies. It's a very similar kind of camera, but much smaller in size. We oftentimes go through people's mouth or their nose into the lungs. Most of the time, people are asleep or under anesthesia, and we look around in the lungs. You might hear about a word called EBUS bronchoscopy. It's essentially the same kind of camera, but if you see that little red strip on the end, that's a little ultrasound probe. So it's endobronchial ultrasound bronchoscopy. So it's the camera with a little ultrasound probe on the end, and that lets me go in the lungs and look through the airways, almost like X-ray vision, and see where these lymph node glands are, or anything in the center of the lungs that you can't see with your eyes behind the wall of your windpipe. And then there's something called navigational robotic bronchoscopy, which are all these new fancy technologies we have to go out in the periphery of the lungs, in the farther depths of the lungs that we, in the past, would have a very hard time getting to. It's almost like a GPS system that guides us through these tunnels into areas farther out. And we could take biopsies of very small spots, pretty much anywhere that they're situated in the lungs. And bronchoscopy, especially as the technology has advanced, is a very safe and actually very efficient and I'd say high-yield procedure. And the benefits of bronchoscopy are that you can check multiple areas at the same time. The risks, which are pretty much bleeding and lung puncture, are very low, usually in the 2 to 4 percentile. So if you have a spot with lymph node glands that need to be checked, you could kind of check everything at the same time. Another form of taking biopsy is a CT-guided bronchoscopy. So this is where we use the word percutaneous, through the skin. And many times this is done by interventional radiologists. So I'm an interventional pulmonologist. These are done by the interventional radiologists. And they use a special scanner to guide their needle into a spot through the skin. And this is a very accurate test, can get to a spot with very good accuracy. The trade-offs are it's a little bit higher risk of lung puncture, typically. Lung collapse can happen in about 10 to 20% chance. The other downside of this is you could really only hone in on one spot during any one procedure. And then the final type of what I call a biopsy, because a biopsy is just taking a sample, is a surgical resection. Is a surgeon to go in and essentially remove the whole spot, the whole mass, the whole nodule, what have you. And this is what I tell people is the most definitive test. It's a test with close to 100% certainty that you would know what this spot is, you get the whole thing out, and you look at it under a microscope, but it's also the most invasive. We oftentimes, because it's the most invasive, try these other methods first and reserve the surgery for when it's needed as treatment, not in a diagnostic sense. Occasionally for very small spots in the lungs where we say maybe this is a very early small lung cancer that would be hard to biopsy, surgery may be the only way. But these are all part of that art of saying what's the best way to get an answer and stage without hurting someone in the process so they could get to treatment. And then finally, what I think will probably be talked about a lot at this conference is what has revolutionized lung cancer, what we call ancillary testing. Other terms for that are molecular testing, genomic testing. It's really understanding these cancers at the genetic level, at the immune level, and the interaction with the immune system. And it's become standard of care to check these things on cancer whenever we do biopsies as well. The word PD-L1 is understanding the interaction with the immune system. We look for something called next-generation sequencing. Rashida is really an expert on these things, looking for all these genetic mutations where we have all these new treatments and approaches that we use for especially non-small cell lung cancer. This can be attained from both biopsies and also from the blood as well. So in my final slide, diagnosing lung cancer really involves getting the answer safely, efficiently, and then getting someone to that really critical piece, which is what do you then do about it? And in the next steps, really ideally a multidisciplinary approach to treatment is the key. Might involve surgeons, oncologists, radiation doctors, pulmonologists, nurses. Nurse navigators are critical, case managers and social workers and palliative care teams and therapists. It's all hands on deck. Now, you might not have all these. A lot of this depends on the approach and the treatment, but it's oftentimes a team approach. And I think hope is critical. It's not just critical, it's realistic. I have patients I've been taking care of, and you'll meet at this conference, with stage 4 lung cancers for 8, 9, 10 years now. And that treatment is really caring for a person living with this and not the disease state. Thank you. So I think I'll have Rashida step up and we'll have a Q&A at the end. Great.
Good afternoon, everyone. Okay, perfect, thank you. Hello, Dr. Lerner, long time no see. I again want to thank Longevity for this opportunity. I'm always excited when I can come and speak and just kind of make it more in layman's terms with all the bulkiness and making sure that you walk away with a better understanding. I know that what I've been tasked with, which is Lung Cancer 101, some of you all may be saying, Rashida, I was forced in that 101 way back when, so this may just be reiterating some things that you are aware about and maybe adding to what you already know, right? And therefore, if unfortunately someone else may have to go through this journey, you can be more of a resource for them as well to make sure that they know kind of the basics. So thank you not only to those who have the diagnosis of lung cancer, but the caregivers who are awesome in making sure that you get to your appointments, maybe relay things to the providers, physician, APPs, navigator, the whole team that maybe you forgot. So clap of hands to our caregivers as well. Yes. Without further delay, let me just get right into this. And please, as Dr. Lerner said at the end, we'll have a Q&A. Please ask whatever questions you want. This is your opportunity. So what is cancer? As we know, cancer is a disease where some of the body's cells grow uncontrollably and can spread to other parts of the body. These cells may form in tumors, which we consider lumps of tissue, and we know them to be cancerous or non-cancerous. And non-cancerous, you may have heard of a term called benign, right? Cancerous has the ability to invade nearby tissue and basically spread, whereas those benign cells tend to not invade or spread to other parts of the body. So this is just a good picture to show you normal development. You have that cell, it divides, it makes this healthy tissue, where when we look at abnormal cell growth, we have this normal cell, there's some genetic changes there, cancerous cell division, and then it just becomes this malignant tumor. And a better picture of this is that cancer begins when changes in genes disrupt how cells grow and divide, which shows you may have this first mutation and maybe your body is able to correct that. But if that first mutation stays there, then you have that second mutation and third one, then you get this whole malignant cell and this tumor growth. And so these changes can result from random errors during cell division, DNA damage from environmental factors, inherited genetic mutations. Lynch syndrome is one thing that comes to mind. And as we age, we know that the body becomes less effective at removing cells with damaged DNA. So what causes genetic changes? Here are some of those listed there. Hereditary, viruses, smoking, UV radiation, cells dividing, and chemicals. So what is lung cancer? Dr. Lerner kind of gave us that overview, and I'll just kind of reiterate that lung cancer begins when abnormal cells grow uncontrollably in the lungs. There are two main types. It's that non-small cell lung cancer and that small cell lung cancer. As we know, small cell lung cancer tends to be more aggressive, more rare than the non-small cell lung cancer, but definitely more aggressive. This is just a picture that kind of shows you the lining of where that non-small cell lung cancer kind of begins, and it is, or the carcinoma begins, and is in that adenocarcinoma. They begin in the epithelial cells, which cover the inside and outside surfaces of the body. Types of carcinomas, you have the adenocarcinoma, you have that squamous cell carcinoma. So this is a high-level overview of of non-small cell lung cancer versus small cell lung cancer staging and treatment. We'll get a little bit into the weeds a little bit later, but this just gives you a high level when we look at the non-small cell lung cancer as it relates to treatment, as it relates to staging, and the different options. As you can see, small cell lung cancer has those two stages, limited or extensive, where non-small cell lung cancer kind of breaks it down a little bit more. So this, again, is an overview. We'll talk a little bit more in details a little later of non-small cell lung cancer versus small cell lung cancer. And as you can see, the incidence of small cell, again, is less, it's 10 to 15%. And then you have that non-small cell lung cancer. For the sake of this talk, we will focus on adenocarcinoma, squamous cell carcinoma, and large cell. Again, another picture that maybe, we as adult learners, we learn differently. So some people, we learn better with those pictures and just kind of seeing, I see some head nods that like, yes, Rashida, perfect. So here it is where it has the types of non-small cell lung cancer, if that visually kind of captures it a little bit better for you. So let's start with adenocarcinoma. So it's a non-small cell lung cancer, as I said, 35 to 40% of lung cancer cases. Most common type of lung cancer, most common subtype in non-smokers and women, usually present peripherally, and I'll show you what that means on the next slide. And then the pathology usually has this glandular differentiation and this mucin production. So if you got your pathology report back, if you're looking at it, you're like, what does this TTF means, right? That's what that means when you see that positive noted. So as I said, this is a picture of it being shown peripherally. So it's peripherally at that lung fields, right? Remember, this is a CT scan. It's cut in half. So the middle is the bronchial. These are the outside. So that's peripherally what it means. Does that mean all the time? No. But for the majority of the cases, adeno is usually noted peripherally. Now let's go over to squamous. So when we look at squamous cell carcinomas, they happen 25 to 30% of the time. It is associated with smoking, usually present centrally. So remember the last one we said peripherally, but this is usually presented centrally, most common found in that large central bronchiole. And then the path is epithelial cells with squamous cell differentiation demonstrated either in IHC or morphologically. And again, you will see that the TTF would be negative on your path results. So as you can see, you see how this image shows that that tumor is closer to that large bronchioles, right there, and that is centrally located is where that tumor is noted. So let's go to large cell. Again, this is still in the non-small cell lung cancer classification. It's rare. It happens about 5% of the time, usually present peripherally. It's a fast doubling rate. You see the pathology information that is noted there, malignant, poorly differentiated, no morphologic or IHC evidence of glandular, squamous, or neuroendocrine differentiation. And as you can see here, and I kind of circle it because it kind of is hard, it's still in that peripheral area. Looks a little different than our previous adeno where we saw this kind of solidified area that was more peripheral. So when we think of the staging as it relates to non-small cell lung cancer, I'm no complete expert. I actually would defer to Dr. Lerner if you have some more exact questions regarding that. But essentially, we're doing T&M. You may see that in your office notes if you're looking in your report. T stands for the tumor size, N stands for the nodes involved, and M stands for metastasis. Has it metastasized outside of that original location? And this is just, again, the next couple of pages is just a kind of more into the weeds about the different stages and how it can break down, because T is very vague, right? That's just the overarching of T1, T2, and so forth, okay? And I do believe, and I'm trying to look for Christy or Jessica for eye confirmation, I do believe these slides are able to be downloaded to them afterwards. I think I said yes.
If you would like to release them.
Okay. Yeah, because if you're like me, I'm taking pictures too, but sometimes I miss things, okay? So they are available for you to kind of have for your own. And so again, here's some more of the staging and the different numbers that we have. So let's look at the treatments of non-small cell lung cancer. And, you know, it's exciting to see how far lung cancer has come. You know, it's just, I've been in oncology for now, I'm not going to tell my age, but at least 20 years. And so it just warms my heart to see how far we're going, where we are now and how far we're still going. And it's so exciting. I have to echo what Dr. Lerner is to know that there are patients that are 5+ years out. And I understand you may say, well, Rashida, that's not everyone's story. And you're right. But it's exciting to know that there are people that's living past that 5-year mark. And so here are some of the treatments, right? So we're not just in that chemotherapy only phase. We have radiotherapy, we have immunotherapy, and targeted therapy. What I would like to kind of go in a little bit deeper on is that immunotherapy versus targeted therapy. Like, what is it? How does it work? What does it target? Who it helps, and the goal and the side effects, right? Because yes, there are so many treatment options now for those who have the diagnosis of lung cancer. However, they sometimes comes with some side effects that we get so excited about where we're gonna get you past 5 years that we forget that there's still side effects that are associated with it. So with how it works, when we think about immunotherapy, it helps your immune systems to fight and attack the cancer cells, right? Because in any person thinks, well, I have an immune system, it should have prevented this, right? So what can we do to kind of increase that identification of your immune system to see this as something that needs to be fought at? So this is how it works. What does it target? It targets the body's immune checkpoint or defenses. Who does it help? Helps those with people without a specific mutation. And what that means is that a patient that may have an EGFR or ALK fusion in first line, it may not be appropriate to give them immunotherapy in that first line setting. So that's what it means when it says can help people without a specific mutation. And the goal is to teach the body to fight cancer on its own, even after treatment ends. So, you know, you may be on the immunotherapy for 2 years and you're like, oh my gosh, I'm a little nervous here. Why can't I get it even further? But the thing is that immunotherapy works, and it doesn't just cut off like chemotherapy. We're trying to ignite your immune system even more, and that's why sometimes those side effects, you may not have had any side effects while you were going through treatment, but maybe 6 months after treatment, you was like, wait a minute, I'm now getting some itching. I have this rash. Where did this come from? Or I have a little cough. My physician, my oncologist thinks that I may have some pneumonitis beginning there. You know, so that is, it's a benefit, and it can also cause some of the side effects of immunotherapy. When we look at targeted therapy blocks the signal that cancer cells use to grow. So remember that EGFR reference that I made, right? So EGFR has proliferated in that pathway there and causing this abnormal growth. And now this targeted therapy is going to come in to try to inhibit that. And so that's what it means when it says blocks the signals that cancer cells use to grow using drugs that target specific changes in the cancer. What it targets, like I said, specific changes in the cancer's genes like EGFR and ALK fusion and KRAS. And who does it help? Only works if the cancer has a certain mutation, right? So if you don't have an ALK fusion, an ALK inhibitor is not going to do anything for it. And then the goal, directly to stop cancer cells from growing and spreading. And then the side effects, usually milder, but can affect organs like skin, liver, or lungs. So this is just an overview of the targeted therapy next generation sequencing that Dr. Lerner mentioned earlier. And I believe that it's only going to get larger. 10 years ago, we weren't even here, right? So, let's just continue to have hope that there's still some other markers that our researchers, our scientists, our oncologists are identifying on a daily basis. So immunotherapy, here's just a picture of how you see how this PD-L1 binds to PD-1 and inhibits that T-cell killing of tumor cells, and how other immunotherapy can block it that also can help with igniting or having that immune system to fight that cancer specifically. So now we're switching to small cell lung cancer. Remember, this happens less often, 10 to 15%. Early, widespread metastasis, most common in heavy smokers. Now, am I saying that it cannot happen in a non-smoker? Absolutely not, right? But majority, almost 98% of patients have a history or active heavy smoker. So again, 15% of lung cancer, the most aggressive lung cancer. As I said, smoking is primarily a risk factor. Early metastasis to the brain, liver, bones, and adrenal glands. Paraneoplastic syndrome is found in up to 20% of patients. So small cell lung cancer staging is very simple. It's either limited, which is what is deemed early, or it's extensive stage, which is deemed stage 4, okay? Or I shouldn't say stage 4, advanced. So the treatment of small cell lung cancer, in the limited stage, if you have ipsilateral lung masses and lymph nodes, meaning only on one side, there is no lymph node involvement. You get chemotherapy, cisplatin and etoposide, plus a lobectomy. If you have positive lymph nodes, then you get chemotherapy plus radiation. And brain radiation, what we call PCI, prophylaxis cranial irradiation, is still considered with the most overall survival benefit, but there's some things that we need to discuss, and we'll discuss that on the next slide. When we talk about extensive stage, that's that contralateral lymph node and masses, distant metastasis, pleural infusions, and the treatment first line is chemo and IO. Symptomatic brain mets can be eligible for whole brain radiation therapy. That's what WBRT means, before chemotherapy. Asymptomatic brain mets is brain mets, you get chemotherapy typically before the whole brain radiation. So I wanted to kind of go in a little bit of this prophylactic cranial irradiations, because there's some discussions that are usually happening with the oncologist prior to whether or not this is appropriate for the individual. So eligible patients, they complete or partial response after radiotherapy, no evidence of brain mets on imaging, and good performance status, and no major neurocognitive contraindications. So what does that mean? If you have a patient that may be more senior and wise, I won't classify as old, I don't like that term, but more senior and wise, that may have a little bit, are already struggling with some forgetfulness, memory impairment, and so forth like that. This is a serious conversation that needs to be had with your oncologist to make sure that you are an appropriate fit and you understand the possible risk or side effects that can happen. So the guideline still says, in the NCCN recommends PCI. an MR surveillance if cognitive risk. So for those patients that maybe the decision was not to do PCI, then there should be some MRI surveillance. And that MRI surveillance is usually every 3 months. And of course, if there's any symptoms that come up before then, typically there's a conversation with the oncologist or the APP team, and then MRI is ordered sooner. ESMO and CHEST also consider PCI. They use shared decision making, especially in older and frail. You see they have older here, I hate that word, wise and frail patients, just to make sure that we're all on the same page. We all understand that yes, this is recommended, but it also comes with some risks. So the bottom line is PCI is a standard option for most limited stage small cell lung cancer patients who respond to initial therapy, but its use must be individualized. It is not automatically given to everyone. So this is my last next to my last slide. Advances in lung cancer research, early detection. Let's talk about this, right? So CT scan uses low-dose CT scans to screen high-risk individuals. Heavy smokers are what they deem as high-risk individuals, 20 packs or more, for early lung cancer detection. Markers in blood and sputum. Scientists are developing tests to detect cancer-related markers in blood and sputum for earlier diagnosis and recurrence monitoring, understanding that this is enabling curative treatment. And then AI and machine learning. So leveraging artificial intelligence to enhance CT scan interpretation and improve detection accuracy beyond standard readings. And I like to add a little bit in there. I think that's great as AI, but we also need to kind of ensure that there's still someone that's checking the AI, right? So AI is great. We love it. I love it too, but we also cannot negate the expertise of a human being to be able to make sure everything lines up. And then lung cancer treatment, target therapy in early stage non-small cell lung cancer, now using that adjuvant setting for eligible patients. So maybe those side effects that we kind of only thought in advanced setting, then we're needing to address that in the early stage. And what does that mean to a potential individual in their quality of life? Immunotherapy in early stage non-small cell lung cancer, incorporated as neoadjuvant treatment before surgery and as adjuvant therapy, follow surgery and chemotherapy. There are continued therapeutic advances in advanced non-small cell lung cancer, significant progress in both targeted therapies and immunotherapy. I spoke about that. And then ongoing research. There's nearly 2,250 active registered lung cancer clinical trials are currently underway. So that is, yeah. Sorry, I did have one more thing. My apologies. So lung resources and programs. Here are the different resources and programs. That's the QR code where you can scan to get more information. I'll leave it up for 5 seconds just for somebody if they want to take a picture of that. And then I know that's a lot of information, so any questions?
Hey, we do have some questions.
Okay.
Thank you, Dr. Lerner. Thank you, Rashida. I honestly wish I had this 6.5 years ago when I was diagnosed stage 4 squamous. This is some fabulous information, so we do need it. The first question is, can my lung cancer change or come back even if I finish treatment?
The question is yes to both. So can it change? And I'm going to assume that you mean the histology or the particular type. So if it was a non-small cell lung cancer, let's say EGFR inhibitor, and we can say, oh, I see an old patient and family. Sorry. If it has an EGFR alteration, there is something what we call a small cell transformation. So that patient that had a non-small cell lung cancer initially now has the risk of transforming to small cells. So yes to that. And then I'm in that perimenopause phase. So tell me the second part of that question.
Can it come back even if I finish treatment?
And unfortunately, yes, it can come back even if you finish treatment. That is the importance of routine follow-ups with your oncology team. That's the importance of letting them know if you have any new symptoms that you can't really explain where they came from. But on the same token, I also want to really state, don't allow it to control your whole life, right? You know, and where that every minute you feel like you can't even live even after you finish treatment. Yes, be diligent, and I know it's easier for me to say I'm on this side and not walking in your journey, but try your best not to let it rob you from enjoying your life and what you have.
You hear this question a lot in the support boards, but does getting a biopsy cause cancer to spread?
Yes, so that question gets brought up a lot, is can you see the cancer? If you do a biopsy, will it drag it and spread it? You know, for lung cancers, as you know, we've had lung biopsies going on for many decades now. We have not seen that to be of a real concern. So even though theoretically it's a risk, the chances are extraordinarily low, and shouldn't hold up the ability to, you need to get an answer and do it safely as well.
Thank you. Sometimes I leave appointments more confused than when I walk in. What can I do to make sure I understand and remember what I'm being told?
Can you repeat the first part?
I'm sorry. Sometimes I leave appointments more confused than when I walk in. What can I do to make sure I understand and remember what I'm being told?
So, you know, that question gives me actually a little sadness because of the state of healthcare in today's world. I tell my patients I'm a more old school type of person. Even though I have all this fancy technology, I like spending a lot of time with my patients up front, because I think that's where the understanding is absolutely critical. We're not here for anyone else other than our patient at that given moment. I think that there's some things you can't control, but if you don't understand, one piece of advice I give family members is set up another visit shortly after. If you need more time, if they can't have more time at that visit, set up another visit shortly thereafter. Bring your questions, have them explain words to you. I try my best to use lay terms, but a lot of times there's so much nuance to it that it might take multiple meetings.
Can I add something to that as well?
Yes.
I agree with everything that Dr. Lerner said. I think it's also beneficial if you have a support, somebody that can come with you, because you're hearing one thing, they're able to hear another thing, or somebody is identified as the person who's going to be the speaker, and the other person is the handwriter, because maybe you go over those questions that Dr. Lerner mentioned prior to, so if they are not mentioned in that time frame or in that meeting, you can bring it up. Another thing that I did when I was in clinic full-time, because I'm no longer in clinic full-time, was that I would allow patients, if they wanted to record it, especially when I did chemotherapy teach sessions, which is so much information, and the individual is already overwhelmed with whatever they need to do. I gave them the opportunity to record what I said, and so therefore we can kind of follow back up and they can replay it at home. And then again, I agree with Dr. Lerner in terms of setting up another meeting, maybe calling, maybe using the EMR message that, oh, thank you for the meeting. Here are some few follow-up questions that I had.
One thing in addition with recording, if you feel that during that initial encounter you really want to be present, or you want your practitioner or provider to be present, one thing that I do is I do the recording at the end. So we do the whole visit. Now, I'm fortunate enough, I'll have a little extra time at the end to be able to do that. Sometimes it takes more time, but I'll do a full summary recording at the end where I could summarize it so they're not listening through 45 minutes, most of which may not be pertinent. So that's another potential option as well. And you could even ask the person you're seeing, if I record, do you have a preference? Would you like me to record it now, or maybe give a little summary at the end?
Thank you. Why isn't surgery to remove the cancer in the lung recommended in stage 4 patients?
Well, surgery, so there's a lot of nuance in that question. Usually surgery is not the curative procedure for stage 4 lung cancer. Patients ask me at the time of diagnosis, is this bad or is this aggressive? The way I break down, I don't think in terms of good or bad. I think in terms of what's the fact and then what do we do about it? And the way I break down lung cancer very simplistically is this something where it's just in one area that you could either just completely remove with a surgery or zap away with radiation? Or is this something that you have to suppress and control more long-standing and just keep it at bay? Usually surgery is relegated to the former, when you could cut it all out and remove it in its entirety, and that would be something that you would go for as curative intent treatment. Not to say that there may be occasional times where surgery is needed, maybe in a palliative sense, if something is causing some blockage or complication and a surgeon needs to go in, but usually surgery is relegated at the earlier stages.
Thank you. What are the risks of bronchoscopy?
So bronchoscopy, the main risk that I quote to my patients is anytime you do any type of biopsy, bleeding, although usually it's very low in bronchoscopy, and it's even lower if you're holding blood thinners. Lung puncture or lung collapse, the word we use is pneumothorax, is also fairly low with bronchoscopy, usually in the realm of 2 to 4%, depending on what you're having done, if not lower than that. More commonly is a sore throat, cough, and hoarseness, which can last for a few days. And then I think it's important for everyone to know on the front end as well, any type of biopsy can come with a risk of a non-diagnostic result. So there still may be more questions to linger, and there's more tests that may need to be done.
Okay, how do they decide which bronchoscopy I should get, and do you have to have general anesthesia for the 3 types?
So usually it shouldn't be up to a person to decide what type of bronchoscopy to have done. It's really asking that question, how do we get you an answer and know where this cancer is in the safest, most efficient way? And you kind of have to rely on your providers to guide you there. As far as many times a provider may say, well, we have a couple options of ways to go about getting a sample. Bronchoscopy is one way. A needle biopsy through the skin, CT-guided bronchoscopy, it's called, is another way. And you could talk about, or even a surgery, a surgeon to go and just remove something. And then you would go through in the visit the pros and cons of all those different ways.
Okay, does staging change? Are we as patients notified if our stage should change?
That's also a great question because we use the TNM staging criteria. Rashida had slides on it that you'll have access to, and you could even look it up. And that is on its 9th edition, and that actually has changed over time. Depending on now which lymph nodes are involved and the location of these lymph nodes, your stage can change. The reason staging is important is because that guides the treatments that many times are offered. So historically, stage 3A disease was something that you would be in that suppressive zone of treating, meaning you couldn't cut it all out. Now we're much more aggressively treating many of these to try to have curative intent treatments. And the way the stage, which lymph nodes are involved has changed over time. As far as maybe the question was, well, if I'm told I have this stage and in my evaluation that can change, absolutely, because there's a clinical stage where your best guess is, and then as you're doing biopsies and doing tests, it could turn out to be something else. So that could change in the evaluation.
Okay. Does squamous cell have biomarkers? Same question for small cell.
So small cell doesn't have the biomarkers that we're used to. Squamous cell, yes. NCCN guidelines, let me start. Typically it's been known to be an adenocarcinoma. But recent, in the last few years, NCCN guidelines have been updated that squamous cells also should be tested as well. Especially if you get somebody that comes into the clinic that's a non-smoker, you definitely should give them the benefit of the doubt and get those biomarkers. When I was in practice full-time with Dr. Levy and Dr. Scott, if a patient was squamous cell, non-smoker, absolutely we were getting biomarkers. Again, small cell, at this time, there are no biomarkers that have any what we call FDA approvals based off of their small cell. I'm not going to say that there's nothing in research, but in terms of it being approved and being able to be accessible, no, not for small cell lung cancer.
If we're diagnosed with cancer, who should be on our team?
So that was touched on in the talk. I like to say the treatment for cancer is a team approach.
Yes.
Which members of the team are going to be at the forefront or the most active at the beginning depends on each person's unique situation. When I said at the beginning, you're found with this possible cancer, who do you see first? Well, every place, every center has differences there. And there's really many times no one right or wrong way. You're gradually building your team, and hopefully you go to someone with expertise that then starts accruing your team for you, whether that's an oncologist first, a surgeon, a pulmonologist, or an interventional pulmonologist. They'll accrue the team. But the members of that team is dependent on everyone's circumstance and situation.
Why are lymph nodes important?
So lymph nodes have a direct effect on staging. So what I tell people is if I have something that might be an early looking cancer in the lungs, in addition to saying I need to do a biopsy of the spot in the lungs, I say oftentimes the first place cancers can spread are the lymph node glands nearby. Many people are familiar with that in breast cancer world as well. You want your lymph nodes to be checked to see the extent, because these lymph nodes are part of the whole body's immune system in fighting areas that are damaged, and they can be involved. And just because a cancer is spread to the lymph nodes doesn't necessarily change everything. It just means now we know which lymph nodes are involved, and we have to make sure we address and treat those. And that has impacts on those first three stages, stage 1 through 3, depending on which lymph nodes are involved and the treatments that are offered.
Okay, last question. What is something you would like us as cancer patients and cancer caregivers to know that our providers may not tell us?
Do you want to start?
First of all, if I can, one thing, every time I hear the phrase cancer patient, there was this amazing individual. She was an EGFR patient that had lung cancer. And she always told me a long time ago when I did some talks with her, you should refer to us by an individual first who has cancer. And her name is going from my mind right now. Blame it on Perry, okay? Blame it on perimenopause right now. But she was amazing. So I just have to say that, remember, you are an individual first. Cancer is just something that has come along your journey, but it does not define you. So just remember that. What I would say as a takeaway of what I would want you to know that maybe your team may not have exclusively told you, because I believe that it wasn't done in error. They just maybe wasn't able, or they didn't remember at that moment to tell you, is that, we're humans. Did I turn my thing? Okay. That we're humans, and sometimes, I don't know what's going on with this, but can you hear me? Oh, thank you.
There you go.
I would say that, as providers, we're humans, and as humans, we can make mistakes. So feel empowered that this is your life, right? You are your best advocate. Your caregiver is your best advocate as well. So ask us if there was something that was not mentioned that you needed clarity on. You have the right to ask us. And I always say that, I think I've said it 2 longevities before, is that, anytime you meet with a oncologist and it's your consult and you're not feeling what they're telling to you, you have questions, you don't feel like everything sounds right, it is your right to, look around to see if you can get a second opinion, just to make sure that you are on the same page. And so I guess I kind of jumbled and did some rambling there, but my takeaway is that remember that you are your best advocate. You know your body more than we know your body. So don't never stop thinking that what you feel is something different. And even if we don't hear you the first time clearly, keep saying it until we hear you that this is not right. Something does not seem right.
Yeah, and I'll just add 3 quick comments there. The first is echoing what Rashida said. I had a very close family member that had lung cancer, which is what was the inspiration for me to go into this very unique subspecialty. And he was told early on, you're a healthy person with lung cancer. I love that phrase. You live with this even in the higher stages. The second thing I wanted to say was, one of the things I hope I conveyed is that a lot of these terms are very broad. People do a lot of research up front. I think transparency is critical. I never shy away from words. I want my patients to know everything and have everything, but sometimes when they do a lot of Googling and research on the front end, they see, sometimes at best, things that are just poorly nuanced or not very applicable to them or the context of what they're going through, many times just flat out wrong or only what they're looking for. I think you accrue your team and you find out what resources they can supply you and go through because, again, Googling some terms which can be extremely broad, even prognostic terms can be very unhelpful or out of context or flat out wrong compared to today's day and age or that person's situation. And I blanked on my third thing, but those are 2 important things.
You know, it's, oh, hello. So there's always grace, Dr.
Yes.
Lerner. No worries at all. Is it just, or do you and Dr. Lerner, right? And have them on your treatment team? Clearly, there is so much more to discuss and share, and there were some fantastic questions that we just plumb ran out of time. Thank you, sir. Ran out of time to address. So feel free, while this session is coming to a close, feel free to grab Dr. Lerner or Rashida and ask them your questions that maybe we didn't get a chance to cover. I just want to say that the question about leaving appointments more confused I know it grabbed Dr. Lerner and Rashida's heart, and it also grabbed mine. One of the things that you will hear in our community is no one, absolutely no one has to walk a lung cancer path alone. Find your people. Find your tribe, whether it's longevity at your cancer center. There's navigators, nurses, social workers, your palliative care team, integrative. Find your people, find your advocates, and know that you've got friends at longevity as well. Additionally, handouts. These handouts were fantastic, both of them. So I want to go back and look at them myself. And our amazing colleague, Jess, that's doing our AV, mentioned that she will have those handouts on the app. We have permission from Dr. Lerner and Rashida to share, so those are going to be near the post-session survey. I don't really know where that is, but it's there. So maybe at the bottom, maybe the side, but you're resourceful, and I know that you can find it. Quick reminder to fill out your surveys. You can use the Event Mobi app, and you're going to get a raffle ticket for longevity swag. Make sure that you go see Belinda at the Project Peer table to cash in that raffle ticket. Our next session coming up is navigating the expected and unexpected finances of lung cancer. That will be recorded by the amazing Jackie Hess is doing that session, and Jamie Knox is assisting. But before we jump into that, let's give a round of applause to Rashida and Dr. Lerner and Amy. Thank you so much.